talk is really about the terrain. We have a few objectives. We're going to try to distinguish the key differences between conventional medicine and functional medicine and how they're really for different things. Functional medicine, you know, if I am having an acute MI, don't wave crystals over me. Don't take me to my acupuncturist, and for God's sakes, don't take to my office. Get me to a cath lab. You know, that's an acute issue. And standard medicine is like better at that, right? So we're going to clarify how a systems-based approach can help us effectively treat chronic complex disease. So that acute MI, yeah, I want to be in a cath lab. But if I have stable chronic coronary artery disease, yeah, that's functional medicine, right? It's a different thing. And then understand broadly how to apply concepts of patient-centered care for patients with chronic disease. This is an overview. I'm going to talk a little tiny bit about the tools. Don't go crazy, you know, don't light your fingers on fire writing, because Dr. Hughes in the next lecture is going to go through those in more detail and more methodically. We have a fundamental problem in medicine, and Dr. Lukaser just alluded to it, and it is really about evidence-based medicine. So evidence-based medicine is the conscientious, explicit, and judicious use of current best evidence in making decisions about individual care. And so good doctors use, you know, their own personal clinical experience, the patient's preference, and the best science. So we have this Venn diagram, and kind of that intersecting area in the center seems like this really sweet spot, right? All right, so we end up with this Venn diagram, as I said, and then we see that the progress of evidence-based medicine, and now we're going to de-emphasize clinical experience, and we're going to de-emphasize patient preference, and we're going to focus solely on the evidence. And then Dr. Ioannidis at the Stanford University, biostatistics, there is increasing concern that most current research findings are false. Most research findings are false. Simulations show that for most study designs and settings, it is more likely for research claims to be false than true. And generally speaking, research appears to be an accurate measure of current bias. Furthermore, if 10 research groups around the world are working on the same problem with a similar design, and one of them finds a statistically significant finding, the probability of that being true is about 1.5 per 10,000. And I find that striking. So I dug into this. I thought, well, that can't possibly be true. Lipitor reduces heart disease by 37% in a relative way. Because if there's a disease that has a prevalence of 3 in 10,000, and you reduce that incidence to 2 in 10,000, the absolute risk reduction is 1 in 10,000, but the relative risk reduction is 30%. And the absolute risk reduction of statins is about 1%. Plavix, we're told it's 30% better than aspirin. It costs about $5 a pill. People are choosing whether to buy food or buy Plavix. The absolute risk reduction of Plavix is less than 1%. Statistics. So a decade of reversal. This is a study published in the Proceedings of the Mayo Clinic, and they looked at all of the featured articles, the main articles in the New England Journal of Medicine over this decade. So, you know, New England Journal of Medicine, considered the top tier medical journal in the world, and they found that roughly half of everything that was thought to be, this is it, we have the answer, this is the best current knowledge, half of it was overturned within the decade. So the reversal of established medical practice is common and occurs across all classes of medical practice. And in this editorial, the same John Ioannidis says, an empirical evaluation of the Cochrane reviews in 2004 showed that something like half of things have insufficient evidence to recommend them. These are common medical procedures. Half of the things doctors commonly do, there's not enough evidence to support them. And that was repeated in 2011 with essentially the same result. An analysis of the overall level of evidence behind Infectious Disease Society of America guidelines. More than half of the current guideline recommendations of the IDSA are based on level 3 evidence, which is opinion. Until more data from well-designed controlled clinical trials becomes available, physicians should remain cautious when using current guidelines as the sole source guiding patient care. And my favorite publication of all of medical literature, Parachute Use to Prevent Death and Major Trauma Related to Gravitational Challenge, a systematic review of randomized controlled trials. Unfortunately, our search strategy found no randomized controlled trials of parachutes. Conclusion. As with many interventions intended to prevent ill health, the effectiveness of parachutes has not been subjected to rigorous evaluation by randomized controlled trials. Advocates of evidence-based medicine have criticized the adoption of interventions evaluated by using only observational data. And critically, we think that everyone might benefit if the most radical protagonists of evidence-based medicine organize and participate in a double-blind, randomized, placebo-controlled, crossover design trial of parachutes. So where do we sit? We've lost the clinician's experience, we've lost the patient experience, and there is no evidence. We're in a bit of a quandary. And we'll talk about that. So let's try to distinguish the key differences between conventional medicine and this thing we're calling functional medicine. You know, modern medicine is a wondrous thing. Modern medicine is an excellent tool for acute care. Modern medicine is a technological marvel when applied properly. And every tool has its highest purpose. And the highest purpose of standard care model is really acute care. The interesting thing is I was told one time that something ridiculous, some ridiculously high number, I don't remember if it was 50% or 80%, but some ridiculously high number of dollars, percent of dollars are spent in the last few days of life. Because as people get sick, you know, we do more MRIs and we do more interventions and we do more things. And my response to that when I was deeply invested in, you know, running a small ICU in a town was, well, you tell me which days are the last few days and I'll stop spending the money. But until we figure out how to make that prediction, it's kind of tough to not spend the money. But the problem is we're using the wrong tool. I want to tell you about John. John's a 37-year-old guy diagnosed with ulcerative colitis about 2 years before seeing me. He started with his primary care doctor and was placed on sulfasalazine and did really well. Initially, he had improvement, but after about 3 months, he had a relapse with symptoms that were worse than before he was on the med. So he was referred to a GI. Makes perfect sense. He was placed on an escalating number and strength of medications. He eventually was placed on a succession of biologics. He continued to have severe symptoms. A surgical consult was obtained and he was scheduled for a colectomy with ostomy, and he was not excited about that. So he talked to a friend of his who referred that person to me. The person was a patient of mine. The patient had actually been trying to get him to see me since he had started having, or since it became known that he was having what was thought to be irritable bowel syndrome. So John was desperate to avoid his surgery. And frankly, I just told him, you know, we're going to try, but I'm a little afraid you're here a day late and $1 short. I mean, this is end-stage disease. You're right up against a surgical intervention, having been on some of the most powerful drugs known to medicine. His sleep quality was terrible because of some anxiety issues we'll talk about in a minute, but also he was freaked out about this disease process. But he did have a really strong support. He came, it's one of those deals where you go in the room and there's everybody and their brothers in there, and it's hard to figure out who the patient is. So he had a very good support system. So I used the IFM tools. And you're going to learn progressively more about these IFM tools throughout the week. I did something really novel. I listened to him. There's evidence that doctors interrupt patients within, something like 17.5 nanoseconds. And it's because they're afraid the patient is going to take too long. Right? They're afraid the patient is going to take too long, so they interrupt, and then they interrupt, and they interrupt. And it makes sense, because in this acute care model, we don't care about all those details. We just want to get to the point where we can lock down physiology and stop this disease process. But we're doing something different. And it turns out if you let people talk, they'll tell you their story. And they'll be efficient about it. And when you interrupt them, they have to keep coming back, So we all have this fear, like, oh my God, I'm going to be here for a month and a half while they tell me about Grandma Telly. It doesn't happen. And then I use this timeline. And the timeline is about sort of, birth to death or birth to current situation. And where does their health break? And become very curious about that break. What happened at that break? And sometimes it goes down and then comes back up, and that's nice. Well, what happened when it came back up? What helped them get better? What happened when it broke down? Explore those areas. And then we use a tool we call the matrix, which you'll see in a moment. And then we're looking for antecedents, things that are predisposing to the disease, triggers and mediators. So triggering things and mediators that perpetuate the illness. And then because we're not just handing people pills. And we know that the compliance for people to take their pills is terrible. Something like 30% of people actually take their pills. People don't take their pills. Well, what about if you ask them to change their lifestyle? What if you ask them to change their diet? When I've mellowed as I've aged, and just a tiny bit less cocky. And it used to be that people would say, well, I'm a meat and potatoes guy. And I'd say, well, you want to die? I mean, it's okay if you want to be a meat and potatoes guy, but how much is it worth to you? I have a little subtler ways of helping people through that now, but it really, it's an issue. And then MLS, that's not multiple listing service. That's actually modifiable lifestyle. We're not getting people to sell their homes. Modifiable lifestyle factors. So John was full term. He was atopic at about 5. He had multiple ear infections between 5 and 7 with antibiotics. He had sensitive stomach from about 5 years of age until the present. Developed anxiety in junior high that escalated throughout his life. Company he worked for was purchased about 2.5 years ago, which caused great uncertainty and concern about his stability and livelihood. He is a paternal grandfather with type 2 diabetes and coronary artery disease, paternal grandmother with IBS. Father was a very stressed guy, type A, very angry. Mom had coronary artery disease and maternal grandfather had coronary artery disease and hypertension. Maternal grandmother had depression and anxiety, maybe from living with the dad, I don't know, or having the dad as a son, maybe. And then mom had depression and anxiety. Maybe from living with the dad. But, you look at this history and it starts to make you wonder, over this week you're going to discover that type 2 diabetes is an inflammatory disorder, coronary artery disease is an inflammatory disorder, IBS has an inflammatory component. You'll learn, again, coronary artery disease is inflammatory, depression and anxiety are probably inflammatory. And what does it do to your autonomic nervous system to live with somebody who's stressed and angry all the time, or to live with somebody who has depression and anxiety all the time? We know from studies on people who use meth, their autonomic nervous system is semi-permanently changed from the constant bathing in these sympathomimetics. Similar thing is going on here. And what happens when you're in fight or flight all the time? There's this thing called prinzmetal angina, and you can even have heart attacks from having autonomic responses. Well, if you have an autonomic response in your gut, you're shunting blood away from your gut. If you're shunting blood away from your gut, you're not healing your gut well. You're leaving fermentable product behind. You're altering the microbiome in the gut. 70% of your immune system lines your gut. So you're shunting blood away from your immune system. So many things happen from being chronically stressed. Symptoms of IBS developed at the time of increasing job stress. Symptoms escalated until diagnosed with ulcerative colitis 2 years ago. So what did we do? Well, we're going to go, my last lecture is really about what we call the 5R, and we're going to go into some details about how we arrived at this. And Tom O'Brien is going to talk extensively about sort of the philosophy of it. We call that dig in, and my talk is about 5R. And Christy before that is going to go through the tools. But just to say, I put him on an elimination diet, and one of my patients said, well, why do you call it an elimination diet? And he said, oh, I know why. After he did it for a little while, he comes back and says, I know why. Because it eliminated everything I like to eat. And it is true. It is a diet that kind of removes common foods. Because you become, especially if you have this disorder known as leaky gut, you become sensitized to things that you're commonly exposed to. So he was already underweight, so we added some healthy fats to help him with his calorie count. He had significant fatigue and muscle issues, so no energy at exercise. We put him on some supplements listed here, and I ordered some tests. So here's his timeline. This is one of the tools we use. On the left side, we have some antecedents, which I already went through, the family history of diabetes and all that. That made me think he has a predisposition to be inflammatory. He has a predisposition to have autonomic imbalance. And then triggering events, job stress, and then these other events, frequent antibiotics, and which probably altered his microbiome at a very early age and probably is related to his atopy and his gut issues his whole life. Company sold is probably another big trigger. And then here is the matrix. So we've got the antecedents, triggers, and mediators along the left. We've got this matrix where we look at these sort of metaphysiological nodes of assimilation, which is digestion, absorption, breathing, things like that, defense and repair, energy, biotransformation, transport, communication, and then in the center, this mental, emotional, spiritual realm, which is often hard to assess because these are very emotional topics. So I try to address that. I sneak into it through the autonomic nervous system assessment. And then along the bottom, the modifiable lifestyle things. How's your sleep? What percentage of your patients actually get 7 or more hours of sleep a night? We live in this all yang, all the time society where people don't sleep. And if they do sleep, they're tossing and turning and worrying and freaking out. And exercise and movement. How many people are just, oh my God, I got to go to the gym. I don't want to go to the gym. How many people are having joyous movement in their life? Nutrition. We talk about get your 5 a day. That comes from 3 to 5 vegetables. So we take the 3 and 2 to 3 fruits and we get to 2 and we get 5. Nobody's talking about get your 8 a day. And that recommendation is for healthy people. Maybe we should be talking to people about 8 to 10. Unless you are, putting them on some other kind of therapeutic diet. Maybe it's a keto diet or this diet or that diet or a vegan diet or whatever. Stress. How do people manage their stress? How do they balance their autonomic responses? And then relationships. So, we talked about this. So in the first week, John stabilized and started to improve on these fairly simple interventions. And I think a big piece of this puzzle was certainly it was some of the things we did, but it was also somebody saying there may be another path. So 6 weeks, we liberalized his diet a little bit. He was still on an elimination diet, but we liberalized it a little bit. And then within 12 weeks, we started to wean him off of some of his non-biologics. his biologics, and then we continued to try to wean him off meds. At 9 months, he was still doing well, so we tried to wean off his regular meds, and his symptoms increased. So we escalated his supplements, and that didn't help, so we did a whole bunch of dietary and supplement manipulation, and that really didn't help, and we just were unable to get him off of his sulfasalazine. However, he was doing better on diet and lifestyle and sulfasalazine than he was on all the other meds plus biologics. So I kind of thought this was a failure, because I'm one of those hypercompulsive, anal retentive, take responsibility kind of guys. And, but, you know, no colostomy, off biologics, off most of his meds, stable and even better on his current regimen. He thought this was a screaming success because he wasn't walking around with a bag on his abdomen. One more story. This is Robin. Robin was absolutely the definition of health, absolutely asymptomatic. She was having a routine colonoscopy that I did. And she was found to eventually, she had a big mass in her, right, where the sigmoid becomes retroperitoneal, right at that junction. And it turned out to be stage 4B colon cancer with mets to her ovaries, liver, and lungs. Prognosis was measured in weeks. She had a massive surgery, took out all her pelvic organs, took out half her colon, took out a third of her liver. Then she had chemo. She was no evidence of disease. That is an acute care model miracle. Prognosis was upgraded to about 2 years. We added functional medicine. This was the full meal deal with laps around the matrix. This is a matrix. We used to call it the web. You know, a spider web, you pull on one little piece of a spider web, it changes the rest of the spider web. So if you make an intervention, you have to reassess your patient to see how things have changed. It's not one and done. I did the matrix. No, the matrix is a continuous assessment tool. So she remained no evidence of disease for about a year, which was actually much longer than her oncologist predicted. So it's not either or, it's yes and. It's not acute care or functional medicine, it's not acute care or holistic medicine, it's yes and. She had a great quality of life up until the very end. She saw the birth of 3 more grandchildren. Her only regret was not being a grandma a little bit longer. Not everything is lived happily ever after, but this is a good outcome.